I'm going to get, so we have Tim's here, I'm Kevin, and Satoshi. And there's Gemma over there, and she's going to give the clinical details to you first, Zahid, okay?
Okay.
Let's go with the case introduction.
Good
We can
evening,
go ahead.
gentlemen and ladies. Today I present to you a case. This is a 4-month-old male, currently weight
Do you want me to push while
3.7
you pull?
kilograms. Here, fertile spontaneous vaginal delivery at full term, normal development tachycardia after birth, coronary
Sorry, let me catch
fistula
up before we do
incidentally
anything.
detected 1 month ago. Recently completed inpatient
stay
treatment
still.
for pneumonia.
I'm here.
Vital sign heart rate 145 mm. Saturation
Remember,
on
store
lumen
this one.
100%. On examinations,
Stop
continuous
the roll.
murmur left lower suprasternal border, liver not palpable. ECG sinus rhythm, LI and LV enlargement, chest clear on auscultations. X-ray increased pulmonary vascular marking, and echocardiogram, cytosolitis, normal venous connections, volumetric LA and LV, severe MR, increased echogenicity of the mitral valve papillary muscle, severe TR, estimated RVSB 65, LCA to RV fistula, LCA and LID dilated, LID grossly aneurysmal and tuberous, ranging to the RV, proximal LCA around 10.4 mm, before range sign narrowing down to the 2.8 mm at connection to RV, radian around 30, normal RCA, preserved by ventricular function. This is echo, so here LCA.
Okay. So, so you heard the case details. You know, congestive failure, small baby.
Chạy.
We'll start with the
Okay.
pigtail aortogram.
Okay.
Next.
It's not fully centered, so we'll show the next one. I think that shows the morphology reasonably. I think you can see the right coronary system. It doesn't seem to be involved in the fistula. And then you can see it's a rather short direct communication, and it's and you can see a separate left coronary. I think you can see the left coronary system filling as well.
So, did you do any selective coronary angiography as well?
Yeah. So we'll show the next run. So a little bit and next. And next. So that's getting close to select. And next, this is probably our best selective, Zahid, with a coronary wire having crossed. Just go back to the one with the coronary wire.
But Kevin, the one you're showing, we can see the circumflex, and we can see the large LED, right? I mean, if you run the angiogram that you did first, but
yeah, just show the actual coronary. Show the actual coronary.
If you run the actual coronary angiogram.
Yeah, the one where we inject with the wire having crossed. Yeah, I think this probably shows the anatomy best.
Right.
I think the flow is high, so the questions would be, how do we find out what's going on in the normal coronary system prior to releasing the device? So our strategy has been to cross the coronary fistula into the pulmonary artery and form an AV guide wire loop. So an ordinary coronary wire was used to it. The Terumo wasn't really, it's a very small baby, the Terumo didn't do it. So we've got some information. It looks like it's a fairly direct connection with the RV.
Right.
Yeah.
I agree with you, and I'm open to any comments from the audience as well. But did you do right coronary angiogram as well?
No, we thought we saw it well enough on the pigtail aortogram not to need to do it. We were pretty happy with that, but I think in a bigger patient, you might well do it. Okay, so you can see we've created the AV guide wire loop.
Okay.
You can see the end snare, which worked very nicely to snare this out. And then, of course, the coronary wire really isn't good enough to be able to deliver a long sheath. We weren't certain at this point whether we should deliver the long sheath from the arterial route, but it's only a 3.4 kilo baby, or whether we should deliver it from the venous route. So we said, well, we'll try from the venous to start with, and if it goes without too much drop in blood pressure and it's tolerated well, then we would we would leave it at that. So here you see the catheter being introduced, and then next one, you can see the Terumo. Next. 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 That Terumo up to the back to the PA, and then snare again. Now we have an 035-inch exchange length Terumo AV guide wire loop. Next.
There's comment. Nick has a comment or a question. Go ahead, Nick. You need the microphone on.
Yeah, very hard to hear.
1 sec. Can you turn the mic on, please? They might be able to. Would you guys help turning the mic on?
Anyway, just while you're getting that sorted out, I'll just show you. Tin has a very nice technique for how he uses the kissing technique. He basically clamps the Terumo wire at the end of both the catheter and the sheath, and then manipulates himself at the groin. He doesn't need anyone else to provide extra tension while he's doing it. And I think this worked, and you can see this worked very nicely. And I don't think it's producing, that there's a tremendously tight guide wire loop being created. So you can see we did manage to get the sheath in there. So yeah, so Nick, go ahead with his question.
Yeah, go ahead, Nick.
Go ahead.
And then Gareth also has a comment or a question.
Okay.
What kind of device do you have in your mind? Because the Amplatz Dr. has additional sizes, something like that. They go through very small catheters. You could have used the arterial access.
Yeah, I mean, that was, would we do a simple slam dunk in with 4 French TorqueView LP and do a 5/6 ADO2 additional sizes, yeah?
Gareth?
Yeah.
Kevin, I've only done a couple of these, but were you not keen to do a balloon occlusion angiogram to see those left branches?
Yeah, I agree. I'm not. So we thought, well, did we have any wedge balloons at 3.5 kilos that would go over our 035-inch guide wire loop? Would we downsize it to the 014-inch guide wire loop that we had already? So we could have done that at that point. But we thought we would do a device pre-release occlusion angiogram. So Gemma got an additional arterial access over in the left groin so that we can shoot a selective angiogram, or at least a pigtailogram, while we're actually, when we've positioned the device. Yeah, go ahead, Zahid.
Hey, Kevin, I'm a little bit in line with what Gareth was saying, because there are a few questions that in my mind has to be answered. Looking at the recent data where there is complete occlusion of these coronary arteries once they are, even when the patients have been on anticoagulation therapy. I mean, what site you want to place the device in is very, very crucial. And since you haven't done balloon sizing, I don't know how will you determine where you're going to place this device.
I think the angiography was actually very good to start with, and particularly the one, I don't know, are you seeing the measurements on the top left screen where we have X1, X2, X3? Are we able to just show that?
We don't see it unless I'm missing something.
Second one.
Second, we can show the second angiogram. Just see, I thought we had a reasonable angiographic understanding of it.
All right. Okay. Good.
This one on the pigtail is good, but the one about, so there's a reasonable angiographic understanding from this, and our minimum diameter on X2 was 3.3 millimeters. X1 we had 6.7 millimeters, and we were going to place at least the occlusive part of the device close to X2.
Right. But Kevin, when you put this device, I mean, there will be some residual shunt, so you really cannot tell unless it's balloon occluded.
Well, but even if you look on this angiogram, you can see that you can see the left coronary system through it as well.
Okay. Well, where are you going to put the device? That's
X2. Yeah, I think. Well, so what we've done, the blood pressure was a little low on the loop, so we have the device in. It'd be interesting to see what people thought they'd use. I know Nick has already talked about using an additional sizes, and I think that was a very good idea. But it is a very high flow setup, and I'd be slightly worried about the ADO2 additional sizes here.
Okay, Bharat has a comment.
Yeah.
Go ahead, Bharat.
No, my concern was that this may be the native LED itself, and what you're seeing about the left system are the obtuse marginals and the diagonals. I have not been able to see the native LED, and by plugging the native LED there, I have a little bit of concerns about the
if you look at the angiogram, Bart, beyond it, it's not possible to occlude anything.
The arteries which are to the left of the dilated fistulous tract are the obtuse marginals,
Yeah.
and the ones which are up away from the tract are probably diagonals. I'm not sure.
Yeah.
But I don't see the native LED. And
I think that has been involved in the fistulous tract for sure.
Yeah.
And the way I'm looking at it is that I see where the fistula enters the RV. I'm happy with that aspect of it, and therefore that's where I want to put the occlusion device.
Okay, go ahead, Kevin. Then.
Okay. So we're going to. So we've got. So anyway, we picked a 7.5 MFO.
Yeah.
I think we thought about an 8.6, and then
Yeah.
we thought about a 9.7, and thought the
You-
7.5 was good.
You mentioned about the
But
kissing.
what was interesting, here's this sort of what we call chasing the dragon's tail. I know it's the year of the cockerel, but chasing the dragon's tail is, I think, a good technique. And I must admit, this is my first time to actually use this device. Is that I was impressed with its flexibility in going around the corner in what is essentially a non-braided Mullins blue sheath. You know we can have problems with these sheaths. Okay? So, yeah, and you can see the way we tried to hold them together with just sort of wedging in the, when I caught up, wedging in the Terumo onto the device as we turn the corner. Okay, so Tin will show you what we have now.
Okay.
And then I think Gemma will do some angiography to see how we're fixed. So we're sort of sitting in the aorta, just outside the coronary orifice, and we're going to do a pullback and see where we stop.
Okay, Kevin,
Yeah.
Dietmar is itching to ask you a question.
Yeah, go ahead, Dietmar.
Yes, very nice case. But I ask me, is it a coronary fistula or is it a valsalva aneurysm with draining in the right ventricle? Because otherwise, I would use the exit 1 and not the 2. What you are doing now? Then
Let's see, just a bit more disc out, Tin. More disc. Just push more disc out before you come back.
Before, yeah.
Just more disc out the sheath. Sorry, just a second. Yeah, just to get a bit bigger there.
Okay,
Yeah,
that's fine.
okay. I mean, if you argue with me that this is aortic to RV tunnel or something like that, I would accept. I would accept that it could be something that is similar to, but it looks like it comes off a coronary orifice rather than the sinus. But how can you tell?
It's still outside.
Yeah, I think
Yeah.
it's, you
So we
have
need to pull in, but
Yeah.
with.
It have some resistance.
Okay, so
And
we have to
I
shrink down.
want to
Okay.
retrieve a little
All right,
bit.
Kevin.
Yeah.
But there are a few more comments from the audience. Behzad? Go ahead.
Sorry, I want to ask you, Kevin, what's the necessity for you to go to the proximal part of the coronary artery? Why didn't you decide
that's
to
fine.
close it in the
Okay,
RV
great.
side?
Great.
Well, we are going to get down there. No, we're
Fine.
pulling back. We're still a long way from our exit point. We think once we're in the RV that you're beyond the fistula.
I think the third,
See, we're getting.
third rim is from the diagram.
Yeah, it still needs to come in more.
Yeah, coming more.
Yeah.
More.
This patient is heparinized, I reckon.
Yeah.
Okay.
More.
Yeah.
It's okay.
I think it's
So
cross.
there's definitely some change and distortion in
fine.
the anatomy, right?
Yeah.
Yeah, right.
Yeah,
But it's a very small baby.
yeah.
Okay.
That's the
Yeah.
point. That's the point.
Yeah, we can check with angio now.
We're going to check with angio as we go.
Yeah,
But
it's-
now it looks like now we actually might be able to provide you with some information.
Yeah. Okay.
what's LAD and circumflex, you can see.
Yeah, we saw the
No.
circumflex before as well, but this is much better now.
It should be okay.
Yeah. So I think we look slightly oversized with the device there, 7.5.
Kevin, can you comment on the beginning of the left coronary artery? Is that a dissection? What is
No, that was there from the beginning.
Yeah, that's
we
fine.
definitely,
Yeah, great.
we definitely
Okay.
didn't cause that.
that? Okay.
We're not owning up to that one. We've owned up to a lot of other dissections.
Okay.
So here we go. So well done, Tin. Brilliant.
Great.
That's great. Okay, so
Okay.
there's no fabric in this device, so it probably tells you a bit about the placement. It doesn't give you the balloon occlusion test you want. I think we've got to be free of any, decent coronary structures coming off that. And even if there is stuff distal, we're not going to get rid of this fistula, we're going to have to get rid of them anyway.
Right. So one thing, you're going to watch the EKG changes?
Yeah, I think we'll wait
a
a few minutes. We'll check the ACT. Yeah.
And then the other important question will be the post-operative or post-procedure management. Are you going to plan, or will you be planning to put the patient on anticoagulation and antiplatelet therapy?
Well, you see, this is very different from coronary artery fistulas in adults. There is some potential for remodeling here and for the native system to grow appropriately. I think one would certainly advise probably long-term aspirin. I think the risk of raise and things like that on long-term aspirin is grossly exaggerated. So I think that's the sort of long-term anticoagulation. Would you give anything on the night of the procedure because you just want to make sure that you don't get propagation? I think you could give some. You could certainly give some unfractionated heparin once you were happy with the access.
Kevin, there are a lot of people who would like to ask you questions.
Sure.
Dietmar is one first.
Go on. What is it? Tell me what it is, Dietmar.
There's a tunnel.
It's a tunnel.
It's not a coronary fistula, and I would recommend a selective left coronary artery injection.
Okay, I think, yeah, a selective left. We could try.
No.
Yeah.
No, my question, Kevin, is with so much of residual flow, how are you going to assess the impact of occlusion of this vessel? Unless you did a balloon occlusion. No, with a device occlusion, with so much of residual flow, how will you know what would be the outcome once this fistula is completely closed? I don't think that you will ever know. My concern is that you are occluding the native left anterior descending artery. I cannot see the left anterior descending.
Okay, Neil?
Yeah, but it doesn't do anything anyway except fistulate.
Kevin?
Yeah?
You've done a great job. Let it go.
Please release me. Let me go.
Yeah.
There's a song.
And I disagree with Dietmar asking for a selective left coronary.
It's a very small left coronary, isn't it?
I agree that this isn't a coronary artery fistula. It's a tunnel of some description.
Yeah.
Great job.
So we happy, guys?
Yeah.
Yeah.
Right.
Okay, please release me.
Yeah.
Okay.
Oliver? Well, one more comment or question.
Okay,
Go ahead,
okay,
Oliver.
yeah.
At one stage you had a loop, guide wire loop with an 018 wire. You could have introduced either a tie shock or a Stirling balloon up that one into the distal end of the fistula.
Yeah,
and that's
I
what
agree.
I sometimes do.
I think that's an excellent suggestion, Oliver. Yeah, no, I think that might keep everyone happy. Yeah, okay. We'll see how it unscrews. Okay. Okay, so it stayed.
Perfect. Can you do you pulled the sheet back. I was going to ask
no,
you if you do.
yeah, no, we're going to do an aortogram now. We can observe for a little bit anyway.
Okay.
I mean, you can see the device changed, but you can see the RV on that disc. It really is quite a nice occluder for this purpose. Yeah, it was nearly as if it was made for it. Yeah.
Okay, great.
I think we're happy in the end with select device selection.
Yeah, I think this looks very, very nice, and the occlusion is even
And we can see
improved.
some left coronary. Can I answer Barrett about the LAD? I'm not sure with that. I think we'd need Dietmar selectives, but I don't think it's worth it. The arteries, the genuine arteries are really small.
There are more comments. Behzad, you go
Okay.
first.
Just a question, Kevin.
Sure.
Good job. But I want to tell me that what kind of antiplatelet or anticoagulation do you use and how much do you
Pressure's
use?
up. Okay.
Aspirin.
Okay. Pressure's up.
I think aspirin in a baby. I think essentially we could be unlucky and get big thrombus. I think in these small, rapid-flowing hearts, certainly giving some heparin tonight is no harm. But I think aspirin should be enough. I don't think we need Plavix.
Thank you.
Okay. Go ahead, Nick.
I think this is a fantastic job. I do not think that I would have dared to do it in the way you did. One question I have. This really.
I love a double comment.
Really, congratulations.
Thanks, Nick.
One question I have is, this is a nitinol device, and the nature of nitinol is to go back to its normal preformed shape. And the part which is now the distal part to the right ventricle, this is infolded. And this will tend to get bigger and bigger. And don't you think that in a young baby like this may be a risk for perforation?
Yeah, it would be interesting to see. I mean, the RV is obviously thicker than the atrium, and this RV is hypertrophied. I suspect we'll get healing fibrosis before it would manage to make its way through.
I'm not concerned about perforating the right ventricle. This is not, but outside of the heart.
Yeah, no, actually, Nick, I mean, I can answer on.
Yeah, you can see it on the cardiac silhouette there, can't you? You see it. You see it changes the shape of the cardiac silhouette a little bit. Yeah?
But even then, it's not going to perforate because when the testing is done on nitinol, yes, it would like to get back to its shape, but it is malleable enough that it doesn't mind if it never gets back to its shape.
Okay.
So that's why the risk of it perforating is actually zero. It has never happened.
Okay.
Yeah.
So anyway, there are a few more comments, and then we got to move on. This is a fantastic case, by the way. Let's clap before we move on.
Thank you.
Joachim has a
congratulations for the case, and this device is really, really revolutionary. They have samples outside, and if you touch it, you will realize it can never erode anything. It's a very soft device. So yes, it's nitinol, but it's soft nitinol. I'm not afraid. This would be a muscular VSD device, maybe, but it's a very, very, very soft device. It's like almost an ADO2AS device.
Yeah. And it tracked around that slightly bent sheet without any problem.
Yeah. Yes. One more comment. I have an experience with a coronary fistula like this, where it entered into the SVC from the quite dilated left coronary artery. And I had used a vascular plug, AVP2, which worked very well.
Okay.
One end was on the SVC side, and the rest of it was in the fistula. And we before releasing the device, we tested we could see all the coronaries, left coronary branches doing very well. So that's my experience, but I thought this is a very good, nice device.
I think so. Thank you very much. Kevin, we're going to leave you.
Okay, thanks very much.
Anything else?
Bye-bye.
We still have lectures to go.
Okay.
All right, thank you.
Bye now. Bye.
Go ahead.
So Tim did all the work.
Just next.
The next speech is
did all the
Cocoon
talking.
device.